Patricia.
So we've got a case presentation today. Tell us about your case, please, Warwick.
This is a 62-year-old man who really didn't have anything much wrong with him until he developed chest pain, which was pretty typical of angina. He was referred to Auckland City Hospital and was waiting to go in there for investigation when the condition became unstable, and he was admitted urgently. His ECG on admission was normal, but his troponin was very slightly elevated at 18, so he was taken to the catheter lab and found to have a severe stenosis in his anterior descending coronary artery. He had a stent placed very successfully and his chest pain went away. He had an echocardiogram before he was discharged, and his ventricular function was normal. So in summary, he'd had a very small non-ST elevation myocardial infarct with no heart muscle damage and a minor elevation of troponin. Now, he was on absolutely no medication when he went into the hospital, but what he was discharged on was the standard treatment given to all patients with heart attacks. So aspirin, ticagrelor 90 milligrams twice daily, atorvastatin 80 milligrams once daily, bisoprolol 2.5 milligrams once daily, and an ACE inhibitor. He was in fact given perindopril 2 milligrams. He was also put on a proton pump inhibitor as gastroprotection.
And what happened after that?
Well, he went home and he felt just tired and washed out, which he thought was just from the heart attack. But then over the next month or two, he developed a number of different symptoms, including breathlessness, sort of like a wheezy sort of sensation that he was having intermittently. He also developed a dry cough, which was only mild, not too much, but the main problem he had was that he felt excessively tired and had difficulty doing exercise. So what his general practitioner did is referred him back to cardiology at Auckland City Hospital for a clinical review.
Right, and was that the initial routine 6-week post-discharge review, or that was an additional review?
No, that was an additional review because for some reason there'd been some delay on his 6-week appointment and he just hadn't been seen. So he was seen at Auckland City Hospital, and the cardiologist there quite reasonably thought that the main thing causing his trouble was the beta blocker. So all he did really was stop the bisoprolol completely because he felt that he wasn't getting angina and thought that might be causing his tiredness and breathlessness, and told his general practitioner to monitor him and get back to him to, if things weren't going well.
And did he feel any better after the beta blocker was stopped?
Well, he felt a bit better, but he just continued on for the next few months, and unfortunately his cough got worse. And the sort of wheezy sort of sensation that he had seemed to settle, which could have been, I guess, due to the ticagrelor, but he was coughing persistently and he was put on a lot of antihistamines for that. And there was really no further communication between his general practitioner and the hospital. His general practitioner just more or less said to him, well, look, you've had a life-threatening heart attack because his lesion had been in the proximal anterior descending, and you've got to always get a few side effects from your medication and sort of carry on. This bloke's a farmer and just sort of manned up and just sort of carried on treatment, but his wife wasn't happy with his condition. That was the main reason that I eventually ended up seeing him.
So at the time when you saw him, how many months was it after his initial heart attack?
So it was about 14 months after his heart attack, and at that point he was still taking ticagrelor and he was having a lot of bruises. Now normally ticagrelor was only taken for 12 months, so I'm not sure why he was still taking that. His GP had continued to prescribe that. He had this dreadful dry cough, which he was being given antihistamines for, and he was just complaining of tiredness and breathlessness. He's a farmer, and every time he went up a hill he was really quite short of breath, but he wasn't complaining of any chest pains at all, and that's sort of the situation he was when I saw him.
So what did you think the cough was due to?
I was pretty certain the cough was due to the ACE inhibitor and that his bruising was due to the ticagrelor. So even before he was seen, his wife, who's very active on the email and that sort of thing, had contacted me, and I told him to stop the ticagrelor even before he got the appointment with myself, and also just cease taking the ACE inhibitor drug because he had normal ventricular function, and the absolute benefit of that at this time was likely to be reasonably small. So yeah, that's what I told her to do before I saw them for the appointment.
And what was your final opinion?
Well, so he came for his appointment, and then he was feeling very much better, both off the ACE inhibitor and off the ticagrelor, but he was still complaining of breathing difficulties. He was all right on the flat, but he just couldn't go up a hill. and he was off his beta blocker, off all the drugs that might be causing that. So I thought, well, we better do a stress test on him to make sure that the angioplasty had worked. And on the stress test, he actually did pretty well. He did 9 minutes, which is not too bad, but he did have ST segment depression, which he really shouldn't have because he had single vessel coronary disease at the time of his angiography.
So as the result of these tests, what did you do after that?
Well, I decided that he needed repeat angiography, and we repeated his angiogram, and I found that he had a quite severe narrowing just at the beginning or proximal edge of the stent at the ostium of the anterior descending, and was able to put another stent in that with an excellent angiographic result. And then what happened then is he's been discharged now on aspirin, clopidogrel, and his atorvastatin.
Right. So what can we learn from this case, Warwick?
Well, I think what we can learn is that when people have a heart attack and go to hospital, they pretty much all get given the same thing, which is a high-dose statin, high-dose a beta blocker, an ACE inhibitor, and the people that need that the most are the most people that are severely affected. The other people benefit from it, but just a little bit. So if they start getting side effects from these medications, then there needs to be an excellent dialogue between the GP, patient and the hospital specialist to decide which might be causing side effects and perhaps withdraw some of these drugs. And if withdrawing one drug didn't work, which is what happened here when the beta blocker was taken away, I think there really should have been more dialogue between the patient, his GP and the hospital. And in actual fact, the person who did most to help here was the wife, because the patient was pretty uncomplaining. He wasn't too worried about himself. He just sort of carried on and manned up that he had a heart attack and wasn't so good afterwards. But his wife didn't like the way he was, and I think she really pushed his for ongoing review.
Yeah, so I think his symptom was coming from a number of causes, and sounds like to me this could have been dealt with at an earlier date rather than dragging it on for more than 1 year. Do you think so?
Absolutely, and I got an email from the patient himself saying that he hadn't felt this good since before he'd had his heart attack, and that's because now all his arteries are open. So initially his problems were side effects from drugs, but as time went on the problem became both side effects from drugs and also progressive disease. And very occasionally when we do put stents and something does go wrong within 6 months or a year, usually it happens by the 6-month phase, which is why a lot of follow-up is done 6 months after angioplasty procedures.
Thank you, Warwick. I'm sure a lot of the GPs can relate to the case that you just described.
All right, thanks, Patricia.